start?
As soon as Dr. Aldevar is here, and he is.
Okay, I guess I'll get started then. Good morning, everybody. So I was asked to talk about detoxification in the setting of pain management, and that's really a brief kind of conversation. So I wanted to extend this into and also a talk about the fundamental science of chronic pain recovery. And chronic pain recovery is a new idea developed by me, Tiffany Newman, Tally Metro, and James Mahoney, who's a psychologist in the Department of Behavioral Medicine and Psychiatry. And basically the way I got to chronic pain recovery, looking at recovery in addictions. And that goes back to 1930s when 12-step AA and NA were developed, or AA actually was first. And recovery has changed a little bit since then, but it's kind of not developed to the degree that maybe technology has or some other things that have evolved over the years. And so I've been putting a lot of thought into what addictions recovery is about. And now that's been extrapolated into a chronic pain recovery model. All right, so let me get started here. So no disclosures. I don't have any conflicts of interest. So here's an outline of the two separate kind of discussions that we're going to have. Part one, the chronic pain recovery. I'm going to define the problem. How can patients also help themselves with chronic pain? So kind of getting to that active versus passive approach to dealing with something like chronic pain. A lot of times patients become passive recipients of healthcare, and that's not really the best way to get involved in resolving medical problems or healing from problems or even recovery. That an active approach is better, and that's what I'm going to argue for. And so the three components of recovery: self-management of pain, well-being, and giving back. And then I'm going to talk about complex system change. And then I'm going to talk about the neuroscience that kind of explains why this is effective. What is the kind of scientific reason why recovery would be helpful in chronic pain? And that's because of something called competitive neuroplasticity. And then the second portion of the talk, I'm going to talk about detoxification. And so basically the principle of detoxification is based on the neuroscientific concept of neuroadaptation. And neuroadaptation speaks to medication efficacy, tolerance, and withdrawal. And then I'm going to talk about detoxification and addictions practice, just briefly, so you get a sense of kind of the core of what detoxification work is like in addictions. And then I'm going to talk specifically about applying detoxification to patients in pain management. So tapering opiates in pain management, tapering and stopping benzodiazepines in patients needing opiates. And I'm also going to talk about gabapentinoids a little bit too. All right, so let's move forward. So how can patients help themselves with chronic pain? Well, I guess you guys know that it's like 20% of U.S. adults have chronic pain, and that comes from an article in 2016. And patients who live with chronic pain have little idea how best to help themselves, in addition to the clinician-provided treatment. And so they kind of get a demoralized, helpless, hopeless sense of things. And so I'm really interested in how we can overcome that and give them a sense of agency and feel some self-efficacy in helping themselves. And so in general, the public and the medical profession often focus on treatment and elimination of pain through medication, injections, surgery, pain pumps, stimulators, chiropractic approaches, massage, acupuncture, physical therapy, and sometimes even use avoidance of the part of the body that's affected. And so what I'm going to argue is that recovery, like we have recovery in addictions and psychiatric disorders, that chronic pain recovery may be the key for how patients can help themselves. So what is recovery? So recovery is a process of improving, sometimes dramatically, one's quality of life to the greatest extent possible. And it means both mitigating problems and constructing a flourishing life. And so that's like kind of a balanced approach to improving life. And it means healing beyond remission or the resolution of symptoms. And it means changing the whole person and changing their behavior and outlook and identity. And someone can achieve cherished life goals, but still have experiencing persistent symptoms as part of recovery, whereas someone else may no longer have symptoms but be far from recovery. And so basically the science of chronic pain recovery is a way of holistically reconstructing patients' lives. And so I divide the science of chronic pain recovery into 3 components: self-management of pain, well-being, and giving back. And I'm going to explore each of those areas. So we know a fair amount about self-management of pain. That's become an area of interest in pain management. And of course, the first thing is expectation management and realistic goal setting. So you can't have unrealistic expectations about the total elimination of pain or total recovery of functional capacities. We're trying to improve functioning, but the expectations need to be reasonable. And then also differentiating good pain from bad pain. So good pain is like fitness-related pain or improving yourself-related pain, whereas bad pain is more when there's pathology involved. And then lifestyle is important in the self-management of pain. We know that diet, there's some evidence that a anti-inflammatory diet can be helpful for the management of pain. And usually we think of the Mediterranean diet as the best example of an anti-inflammatory diet. And so that means eating vegetables and legumes and nuts and seeds and using olive oil and fish 3 times a week. So that kind of diet can be really helpful to reduce the inflammation and help with pain. And then movement is important, restorative sleep, having a good mindset, so a stubborn hope and a growth mindset and conditional optimism. And then I like the self-actualization lifestyle model. So that's looking at Maslow's hierarchy of needs and his different kind of levels of self-actualization. And so you have like physiologic needs and safety needs and belongingness and love needs and self-esteem needs and cognitive needs and aesthetic needs, and then actually you self-actualize after you accomplish all those needs. And so I think you can base lifestyle on that. Then you have to challenge catastrophic thinking. So when people experience pain, they kind of think, oh, there's some kind of harm going on here. There's a harm alarm. And but chronic pain can persist even after the site of injury is healed. And so the harm alarm may not be kind of an accurate assessment of what's happening. And so people have to challenge that catastrophic thinking. And then pacing activity is important. So overexertion or excessive activity exacerbate pain, while some activity can be helpful and promote better functioning. And so you have to pace activity appropriately. And then mental toughness is a good quality. So we think of stoic people who are mentally tough. And, you know, in sports, they say pain is weakness leaving the body, or in the military, they say that. And you want to kind of feed the courage wolf and starve the fear wolf and cultivate great self-talk and visualization. And so all those kind of skills help people become more mentally tough. And then stress recovery is so important in self-management of pain. And so you want to develop unwinding routines. And stress without recovery depletes us. So, you know, stress recovery is the new fitness. So we used to think of fitness as endurance exercise and strength training exercise. But actually the new fitness is stress recovery. And so finding ways to recover from the difficulties and stresses of physical activity or life itself, you know, the social burden and the environmental burden. So you want to be able to recover from stress. And then meditation and mindfulness, which is a way of unwinding actually, but uniquely mindfulness can bring that deep restoration. And it's been shown to be helpful for lower back problems. In mindfulness, you kind of get a detached observational witness kind of to your thoughts, and you're a little bit detached from the here, the present, and a witness consciousness kind of helps with dealing with pain. And then yoga. So I know of a patient who has ankylosing spondylitis here in the pain clinic who did beautifully with yoga. And so yoga can counteract chronic pain. And then relaxation techniques. So we have progressive muscle relaxation, where you systematically tense and relax each different muscle group. And then 4-4-8 breathing. So breathing in through your nose for a count of 4, holding for a count of 4, and then breathing out for a count of 8 to push more air out and make you automatically take deeper breaths in. That's all a good relaxation technique. They use that sort of thing in the military. I don't know if you ever heard of box breathing, but like in combat, which is one of the most stressful things that people experience in the world. They use breathing exercises to help people calm down. And breath therapy has been helpful for back pain. And then self-hypnosis is helpful. So this is getting back to that passive versus active approach to pain. So people think, someone's going to hypnotize me, but actually people can learn through experience how to hypnotize themselves. And it's a combination of relaxation and suggestion that helps people dissociate away from the pain. It's kind of like if you watch a movie and you get lost in the movie and you lose track of time. It's that dissociating away that allows kind of the pain to go to sleep and the rest of the mind is awake and alert and functioning, but you dissociate it away from the pain itself. And it's a pretty powerful technique when people learn how to use it. And then distress tolerance. Some people, especially people with psychiatric disorders or adverse childhood experiences, can't tolerate much distress, and they want to anesthetize every little bit of distress that they have. And so distress tolerance is important in psychiatric disorders and addictions, but it's also important in pain management. And so one technique is softening into the pain. And so by softening into it, instead of resisting it, you're allowing it and softening into it, and that can help. And looking at distress as this too shall pass. So, a lot of times with discomfort or distress, it comes in waves. And so if you can, think that this shall pass over some time, that kind of hopefulness and sense of being patient with things can help distress tolerance. And then detachment, I was talking about mindfulness. So detachment can be helpful. And also we're inoculated by stress. So stress inoculation is basically saying that stress is like a flu shot. And so if you inject the virus into your body to fight the flu and you fight it off, and then when you're exposed to the flu, you're resilient to it, stress is kind of the same way. So if you go through something stressful, it's difficult and annoying and you hate it. But the next time you're exposed to stress, you're like, oh, that's not so bad. I've been through so much. And so distress tolerance builds by a kind of an inoculation process. And then also differentiating good pain from bad pain. And the reason why I bring this up is because if you can find your silver lining in the pain experience, it kind of enlarges the good pain concept. And so it's always nice if you can find something about the pain experience that, even though it's miserable and there's a lot of negative about it, if you can find something positive, you're like, this is making me, more empathic, or, I've become a tougher person dealing with this, or whatever you can find the silver lining. And then healthy activities and hobbies, employment and education. So all these activities are the antidote to boredom. So you get goals in these areas. And idle time and boredom can exacerbate pain. So you can have a kind of a full life with healthy activities, hobbies, employment, and education. And acceptance is so important in distress tolerance. So basically, people experience themselves less defensively when they're accepting. And Lisa Paul, who used to be a therapist at the Department for Behavioral Medicine and Psychiatry, says that just like the way you can fall in love, you can fall into acceptance. And so it allows healing to take place when you have some acceptance. If you think about the motto of Alcoholics Anonymous, God grant me the serenity to accept the things I can't change, the courage to change the things I can, and the wisdom to know the difference. So that kind of mentality of acceptance can help in the management of pain. So what about well-being as part of recovery? So human well-being is both made and grown. And so I'm talking about love, work, and health. So a flourishing life is about flourishing in love, work, and health, all three areas. And so you can have the assembly of discrete parts to accomplish that, and you can have the growth of systems. So all that's about well-being. And so what is the assembly of discrete parts? Well, this is going to cover some similar things that we already covered, but the right food, empowering yourself through fitness, restorative sleep, the right mindset, building mental toughness and strengths, stress recovery, cooperation, trustworthiness, deep responsibility, gliding well socially, building a favorable reputation among knowledgeable people, financial security and economic strength, ruling your spirit well and building beauty into your life, and even making something beautiful of your life. So all that's kind of the parts of assembling well-being. And then also you can have the growth of systems through leverage. And what I mean by that is that you want to have some tension that kind of impels the person or evokes the person to become more well. And so this is kind of the art of wooing nature, that we can evoke well-being in people through leverage. And so one way is the discrepancy between where their life is now and where they want to be. And then also an enriching environment. So we think of the environment and genetics as being the determining factors of who a person becomes. And so you can't really, we are learning how to influence genetics, but maybe just starting to, but we can certainly influence our environment. And so the more you do with your environment to make it enriching, the better leverage you have on your well-being. And then also from the pressure of personal values and mission, you get leverage by investing in your future. So if somebody invests in their education or they invest in fitness, things for their fitness or anything you can do to invest for your future can improve in well-being. And then compelling challenges can create leverage. And how people advertise themselves through their attire. So yeah, the way that somebody dresses kind of impacts them in a leverage kind of way on themselves. And then their language. So people have like a cast to their language, how formal is their language or how informal is it? And how does that affect kind of who they become? And so the way you look is a visual promise or a metaphor or a visible symbol. And so it's a promise to other people, but also to yourself. And so you kind of have the leverage produced by the need for self-concept consistency. And so if you dress well, especially as a clinician in medical care, if you dress well, that impels people to interact with you expecting good health care. And it also forces you to kind of deliver better health care because you're pushing yourself to be consistent. Okay. And then also seeing is believing. So like with Alcoholics Anonymous, when somebody goes to an AA meeting and they see somebody who is successful with the kind of problems that they've had and they've been sober for 30 years, that seeing is believing. It gives them self-efficacy. They believe they can do it themselves, and that leverages their own success. And so I deal with groups of patients in the high-risk pain clinic, and people see people being successful, and it makes them believe, hey, this is something that's an avenue to success for me. And also having a compelling reason why. So if there's a reason why the person wants to grow or improve, that why creates leverage. And then in the addictions field, we think, people have to hit rock bottom. That things have to be really, really terrible for them to kind of decide they have to turn things around. There's enough leverage to make a change. But some people have a high bottom. And so, it doesn't have to just be consequences that motivate people. Sometimes the consequences can be pretty slight to make somebody say, look, I need to do something here. And then the drama of a person's environment or life can affect them. So what about the placebo effect? So you think of, kind of expectancy and hope is creating the placebo effect. But actually that's created by the drama of healthcare itself. So the patient getting the placebo is experiencing the drama of healthcare. And so that creates a leverage that impels people to improve their health. And so even the drama, if you think about a coach giving a pep talk before an important game, the drama of the coach's talk impels them to win or be successful. And so drama can create leverage. And then the outside pressure of family or friends or competition. And then drives, needs, incentives, and reinforcement. So for drives, Freud said we have libido and aggression. and that those drives can be fused and channeled into constructive things. And we also have a drive for homeostasis, so our body is always seeking stability, and as a kind of a natural drive for us, and so that can create leverage. And we have needs for confidence, so to be autonomous, competent, belong, achieve, have power, have meaning and health and self-esteem. And then reinforcement and incentives, so like contingency management and addictions, that you pay people to stop using substances. And so you can use reinforcements like that to shape people's behavior, or even our paychecks, that we're paid for our employment or to get promotions or opportunities that are exciting to us. And so those incentives and reinforcement make us want to perform better. And so all that's leverage on us to have more well-being. So in the presence of leverage, we adapt, align, and self-organize coherently to resolve incongruity and the tension that's created to create a new emerging structure. And so what I'm suggesting is that we engineer the leverage or engineer the tension to evoke a flourishing life. And it's always going to be updated, and it becomes very nuanced, I think. That too much tension, I think, can cause problems, but you want to kind of, tailor this tension in your life to promote well-being. And then what about mitigating problems? So there can be problems in love, work, and health, and we need to mitigate them. And people can have multiple life domains needing repair. And so we need to figure out what's wrong and get it fixed. And one of the keys to fixing problems is actually to fix the process. And when you fix the process, the problem is solved. And I think we have to be realistic. Of course, we're talking about expectation management. So, chronic pain itself may not be able to be resolved fully, but you can still look at mitigating problems as much as possible. So what is well-being? Well, it's earned health confidence, looking well, feeling well, thinking well, and doing well. So what is the last component of recovery? Giving back. And so I'm talking about community service work, helping others. When you help people, it gives you a transcendent feeling. I think all of us who do clinical work kind of get that transcendent feeling, giving back to the community. And then citizenship, be a good neighbor, respect the environment, vote. So all those ways are part of giving back. So I want to talk about complex system change. And so what we want to do in recovery is the system enough to create a new stability. And so just making one change in a single area may fail to tip the system into a stable state. And so the chronic pain may continue. And actually, if you only make one change, it may kind of be so unstable that it kind of goes back to to this the way it used to be. It sort of undermines the attempt to change. And so changes within multiple areas have a synergistic effect that help tip the system into a new stable state. And you can have changes in one area that spill over into others through interactions between domains, tipping the system into greater stability. And some system changes may have a good fit for the person or be pivotal kind of changes. And then you get an upward spiral of an evolving system to cultivate well-being. And so I want to talk about the neuroscience behind chronic pain. Norman Doidge is an expert on neuroplasticity. And if you want to think about neuroplasticity in a simple way, basically neuroplasticity says that you get good at what you practice. And so if the brain is practicing illness, it gets good at that. And if the brain is practicing well-being, it gets good at that. And so the concept of competitive neuroplasticity says, well, look, we only have so much cortical real estate. And so if the brain is occupied with practicing good self-management of pain, well-being, and giving back, it kind of takes over the real estate that was being used for pain processing and perception. And so you kind of compete away the pain part of the brain processes, and it kind of recedes into the background. And so that's the whole concept of competitive neuroplasticity. And that concept makes sense in psychiatry also. You know, that patients are practicing their anxiety or their depression, and they instead focus on practicing well-being and giving back and functioning well and positive aspects of functioning. It kind of, the other things dissipate out of disuse. All right. So utilizing the fundamental science of chronic pain recovery means not just to put out the fires of chronic pain, but to ably govern fire itself. And so we're not just, you know, patching up pain here, but we're actually looking at kind of the mechanism by which we can govern this aspect of functioning neurologically. Any questions about chronic pain recovery? All right, I'll move forward into detoxification. All right, so detoxification, the setting of pain management. So detoxification is kind of a core aspect of addictions work. You know, when people are imminently in the throes of addiction, the first step is to help them get off of the substance that is out of control in its use. And so part of that may involve detoxification. So what explains why detoxification is necessary? Well, basically it's about neuroadaptation. And so one way you can see the evidence of neuroadaptation is through the delayed response to medications. So in psychiatry, we treat people with antidepressants or antipsychotics, and it can take a couple months to get a maximal benefit from an antidepressant. So this is not an immediate effect at the receptor site that's causing something immediately in response of the patient. You know, that there has to be second messenger effects that are doing things in the nucleus of the neuron, and changes are happening in the cells and circuitry that takes a while. So there's a neuroadaptive response to the presence of medicine. And so we see that with tricyclics and SNRIs and neuropathic pain. And, I think any kind of neurologic treatment, you're going to have neuroadaptation. And so also tolerance and withdrawal are evidence of neuroadaptation. And so tolerance, that it's going to take more and more and more for the clinical effect or for the euphoric effect of an abusable substance. And then withdrawal, when the substance is removed, the brain has to kind of adapt to the absence of the substance, and there's going to be effects that occur. So how does detoxification and addictions work? Well, so basically what we're up to here is tapering cross-tolerant medicines. And so like for alcohol, we use benzodiazepines. There's evidence that Tegretol can be helpful as a cross-tolerant medication. Even barbiturates are used, like for benzodiazepines, barbiturates can be helpful. The key to detoxifying somebody with a cross-tolerant medication is a 10 per 20% decrease per day at the most rapid. And so we tend to use detox protocols in addictions. So if somebody is admitted to a dual diagnosis unit or a medically managed inpatient detox, they're going to be on a detox protocol where there's a gradual tapering of a cross-tolerant medication over a period of days. And another part to this, just in addition to the 10 to 20% decrease, is symptomatic relief. And so like for opiate withdrawal, we're going to have something for diarrhea, something for nausea, maybe even something for pain, if there's breakthrough pain, if somebody's detoxing, if they're detoxing off of opiates, they might use something for pain. And then withdrawal scales, so a CWAS scale or the COWS scale. So CWAS is for alcohol, the COWS scale is for opiates. So this is kind of an objective way of measuring the level of withdrawal to help decide how much medicine is needed to, you might have some breakthrough medication available in addition to the protocol for just the scheduled taper. And then medically managed inpatient versus outpatient. So if somebody has a history of DTs or seizures or complex withdrawal, that's somebody that's going to be detoxified in a medically managed inpatient setting. And if somebody has kind of simple withdrawal processes, this is something you might do as an outpatient. So what about tapering opiates in pain management practice? So ideally, the literature kind of says 20% decrease per week is ideal. And you can go faster, at 10 or 20% per day is possible to be that rapid in tapering somebody. But the longer someone's been on the medication, if they're elderly or fragile medically, the more trouble you're going to have with detoxifying someone quickly. And so if there's not an imminent need to get someone off of an opiate quickly, 20% decrease per week is the best way to go. And then you want to slow down at lower dosages. So remember, it's the percentage decrease. And so, if you're just going by milligram increments to detox somebody, as you get to a lower and lower dose, that milligram increment is going to be a larger and larger percentage of the total dose. And that's what the patient notices neurologically and neuroscience-wise on receptor activity is the percent decrease. So as you get to lower doses, it helps us slow down the taper, and just keep in mind the percent decrease that's involved. And then tapering and stopping benzodiazepines and gabapentinoids. So again, 10 to 20% increments for reduction. And sometimes it's even done as rapidly as 25% every 2 days. And again, slow down at lower dosages. It may require a slower taper if taking high doses for a long time or elderly people. And if someone has severe withdrawal or seizures, they may require inpatient treatment. All right, so any questions about chronic pain recovery or detoxification? Was that helpful?
Very good.
What do you think of the chronic pain recovery concept? I like the idea of patients being more active in their approach to chronic pain. And I know it's hard to get people to do that. Like when you think of, for example, if you give somebody a medication, you give them a paper that shows the side effects and how to take the medicine, that goes in the trash, right? They don't look at it. They just want the medicine, just feel better. And they're very passive recipients of medical care. And so I'm interested in how do we impel people to be more active participants in their healthcare? What do you think about that?
Well, my background was in educational psychology, and so this is right down that highway. I think it's choosing the correct report in order to get the behavior you want. And so that's where guys like you who can delve deeper into past histories and some of the psychological beliefs and things that are ingrained can find that trigger that you can then use to get them to move towards more wellness. On the other hand, you have a unique lever of the medication. And so if the individual wants the medication, it's a very strong motivator to perform in other areas in order to continue to get their medication.
Yeah, that leverage concept is pretty fascinating. That goes all the way back to my training as an addiction psychiatrist and my fellowship. In 1997, I think I learned about that. I had a social worker who was working with me, and he said, you just have to find leverage. And that's stuck with me for a long time. It's kind of an aged thoughtfulness about this idea that I've been working on it for a long time. And I think we really need to think about how do we leverage people into greater well-being and health, and instead of just ameliorating symptoms. Any other questions?
Thanks, Jeremy.
You're welcome. Take care, you guys.